Hello, good evening, everyone. Thank you for joining us this evening. Thank you for making time to be here with us once again for the Health Communication Masterclass. And today we'll be looking at family planning options, that is the methods, products, and technologies within the market. So quickly, I just want to say hi to individuals who are on the call. It's going to be kind of a nice breaker for us. So good evening, John. How are you? How have you been? You're able to unmute your mic so that we can hear your voice. This is also an opportunity to test if your microphone is working well and that your audio is equally working. I see Beatrice. Good evening, Beatrice. How are you?
Good evening, I'm fine.
Fantastic. Thank you for joining us in good time. Lovely to have you here. I hope you're keeping well.
Yeah, I'm well.
Fantastic.
Thank God.
Thank you so much. Let me say hi to Patty Mariama. How are you? I hope you're keeping
Hi
well.
everyone, can you hear me?
Yes, I can.
Hi Juliet, hi everyone. Nice to meet
Hi.
you all.
Nice to meet you as well. Thank you for joining us in good time. Much appreciated. I see Jadida, Jackson. Hope you're keeping well. Good evening.
Good evening, everyone. I hope you're well. I'm good. Yeah.
Fantastic. Thank you, Jadida. Lovely to have you here. Mercy Gatli, good evening. How are you?
Good evening, Juliet and everyone. I'm very well. I'm looking forward to the session. Thank you.
Thank you so much. Thank you. Lovely to have you here. I have only said hi to the ladies. Let me see. I can see Dr. Kasam. Good evening. How are you?
Good evening. I'm fine, thank you. I hope you're all well. I'm looking forward to today's session as well. Yes.
Fantastic. We are doing well. Thank you for joining us in good time, and it's lovely to have you on the call as well. So I see, who else can I see? I'm looking for gentlemen. Ahmed Abu Bakar. How are you? I hope you are keeping well. And thank you for joining us in good time. So with that, that's kind of a nice break and just testing that our microphones are working well so that you are able to engage with us well while you're continuing with the session. We have prepared some quite session is to have a dialogue with you as well. Yeah, it's not a lecture, but more of a conversation between the facilitator and the entire room as well. So please feel free to engage with us on the chat. Feel free to raise your hand and mute your mic. Just share your thoughts with us as well. So in the interest of time, I want to share a pre-survey with us so that you can let us know how you're feeling and maybe just answer a few questions with regards to family planning. I have posted the link on the chat, but I'm equally sharing my screen so that you are able to scan the QR code. All right, I hope my screen is visible. Fantastic. Right, so this is more of an icebreaker just to gather some insights before we start the session itself. So you can scan the QR code that is on your left, or you can use the link that is on the chat. Okay. Then we can answer 5 questions that we have on the survey. And the first one says, how are you feeling today? That's more of a mood check this evening. I hope we are not having challenges. You can scan the QR code, or you can click on the link that's on the chat to respond. Mhm. Feeling cool today. Thank you. How are you feeling today? Thank you. Excited for the session. If you're having any troubles, you can let me know. The link has been posted on the chat as well, but you can easily scan the QR code that's on the left side of your screen to let us know how you are feeling today. Just engaging with us on this pre-survey. Optimistic. Thank you. Okay, keep your responses coming in.
Juliet, you will bear with me.
Mm-hmm.
I'm in Mombasa and I'm up and down, so I may not be able to coordinate very well.
Mm-hmm.
Yeah, we're in the 22nd National Association Conference.
Oh, that's
So
all right.
I may not be able to coordinate so much.
That's all
But
right.
I'll keep in the meeting. I'll remain in the meeting.
Oh, thank you. Thank you. You can also just be interacting on the chat wherever possible. Thank you so much. What is family planning? In your own words, having the power to decide when to start a family, methods that help you choose when to have a child or to start a family. Thank you. Keep your responses coming in. What family planning methods do you involve? Okay. Pills, oral contraceptives, and implants. Thank you. Thank you. Okay. Thank you. If you've just joined us, we are on the pre-survey form. We are just gauging to see some of the understanding that we have before we share the content that we've prepared this evening. So please feel free to scan the QR code or click on the link that has been posted in the chat and just let us know and just engage with us on this particular form. And this next question says, have you heard of any injectable family planning methods? And 67 of us have said yes. All right. Thank you. And what are your expectations for this particular session this evening to learn more, to improve your knowledge on family planning, discussions and hearing from others? Thank you. And to have an engaging session. Thank you. So keep your responses coming in. I'll equally still post the link on the chat for those who have just joined us. And with that, I want to welcome our facilitator for this evening, and that is Dr. Wendy Orenge. She's a pharmacovigilance specialist, and she's equally a pharmacist working with African Pharmaceutical Network. Maybe you have been able to interact with her over the course of time, and this evening she'll be taking us through this particular session. So please feel free to engage with us, feel free to text on the chat, feel free to interact with everyone within the room and get to enjoy yourself. And with that, karibu sana Dr. Wendy.
I thank you so much. Thank you so much, Juliet, for that wonderful introduction. Karibu sana everyone for joining this session. So today we are going to talk about family planning methods, technologies and products in our markets. But before we start that, I would like to welcome back everyone who had joined us during our first session, which was last week. We talked about different aspects of health communication. And for those who are not able to join, we can still send you the slides from the last session. I saw very interesting responses to the questions, especially the ones we asked methods and products for contraception. Without any further ado, we can start the session for as Juliet shares the slides, maybe I would like to hear for the new people who are joining us today, maybe please feel free. Or I can choose randomly. I'm seeing a few people here who are new, so I'm just gonna say anyone random. John, are you in a position to talk?
Hello, everyone. Yes, I am.
See on the chat.
Kindly pardon the question. I think
Ma'am Chua said hi, everyone. Hi, Jeremiah. I hope you're well. I'll also choose someone from last week's session. My very good friend, Mercy Gaki. You can unmute and say hi. You can.
Yes, please. What
If
should
you're
I
in a
do?
position to speak.
I had said hi at the beginning and I can. Yes, I am. I don't know if it's my internet that is a bit choppy, but hi, can you hear me?
That's the case. We can start this session.
Hello,
I think
Mercy,
can you hear me?
are you speaking? I can see you're speaking, but seems your mic is and it's muted. You can unmute.
No, Mercy is audible.
We
I
can
think it's
hear
Wendy's
Mercy.
network that has a problem.
Yeah, we can hear Mercy well enough.
It's okay.
So, hi everyone. I had said hi earlier, and I think it's your internet that is a bit choppy, Wendy. Maybe you could move a bit far from your router. That could be the reason. But I'm well. I'm so glad to be here. I invited Kate, and I'm glad that she's been able to join. Thank you all.
Hello. Can you hear me now?
It's getting better. Could you keep talking, and then we will
If
tell you how it's
you're
going?
able to. Hello. Can you hear me now?
Hi, Wendy. We can hear you now.
Kindly, if you hear me, give me a thumbs up. Thank you, Mercy. Okay, we can begin today's session. I've shared my slides. If you can see them, kindly give me a thumbs up. Thank you for that. Okay, so we can begin on today's session. So one of the questions that we asked on the pre-survey was, in your own understanding, what family planning is? And I saw very good answers. Some of us said it's preventing pregnancies, choosing when to have children, and all that. And all those are correct answers. So family planning is essentially the process of freely and responsibly anticipating, planning, and attaining the desired number of children. This can also look like spacing and timing of these births. And most of the time when you talk about family planning, we talk about contraception. It is a part of family planning, but it's not the only part. Also, treatment of involuntary infertility to allow people get children is part of family planning. So all that is family planning. But today we are gonna focus on contraception, of which contraception is the act of preventing pregnancy, and this can be through a device, medication, procedure, or behavior. And family planning is a right that everyone who's within the childbearing age should have access to. And this is very important because it allows everyone to be able to decide when to have children, therefore avoiding unintended pregnancies and births. Another reason family planning is important is it prevents pregnancy-related risks. So as you've said, today we're going to focus on contraception, and there are various methods of contraception, and they aim at stopping the different processes that take place during conception. So this can look like preventing ovulation or delaying ovulation. It can look like interrupting the implantation process in case fertilization has taken place. Therefore, if we interrupt these processes, we come up with different products that can aim at interrupting these processes. For example, we have different products like hormonal products that usually aim at disrupting the menstrual cycle, particularly the ovulation process. And the various hormonal products we have are like oral pills, we have injectables, we have some hormonal IUDs, we even have implants. All those interrupt or rather disrupt the normal hormonal menstrual cycle. But yes, and then we have some methods that physically block pathway of the sperm during the intercourse. And we have things like barrier methods, and these include condoms, we have cervical caps, as we will see later. And another process that prevents conception, or rather another method, is abstaining during the fertility window, or the withdrawal method, which is scientifically called the, anyone who can say the scientific name of withdrawal method? Juliet, you can help me choose someone.
All right, let's see. Let's try. Was someone speaking?
Coitus
Right.
interruptus.
Fantastic. Yes, I also learned it last week. Thank you.
Yes, I'm very interested. Coitus interruptus. It's one of the methods for preventing conception. And then we have methods that target the implantation bit of the conception process. And this include intrauterine contraceptive devices, which are placed on the uterine cavity, most commonly known as IUDs. We've heard of copper IUDs, we've heard of hormonal IUDs. This is the process they target and disrupt. We also have surgical processes like tubal ligation and vasectomy, which are more permanent, and they tend to disrupt implantation or remove parts of the body that are essential in the implantation process. For example, tubal ligation involves surgically removing part of the fallopian tube and tying it. For vasectomy, as we'll see, it targets the vast difference in men. So those are the methods we have, and we will go into looking at the general categories, and then we will go deeper into the specific categories, looking at the way they work, the mechanism behind them, the advantages, limitations, and essentially what to do in case of adverse effects that come from using these methods. So again, here I highlighted the pregnancy process and how these various methods we've said affect the different parts of the process. For example, we've talked about the hormonal methods such as the pills, the patches, injectables, and implants targeting the development and ovulation, the development of the egg and the ovulation process. So there, as you can see, it is well highlighted, suppressing the egg development, blocking the egg release, and then we have stopping the sperm from meeting the egg. These are our barrier methods. And then also preventing implantation of the fertilized egg. We have our copper IUDs, and even hormonal IUDs can work in that part. So let's get into hormonal contraceptive methods. So under hormonal contraceptive methods, they work, as you said, by disrupting the maturation of the egg and releasing of the egg into the tube. So when you talk about hormonal contraceptives, we have two types. We have those that are combined, and these ones have both estrogen and progestin. And obviously it is the synthetic hormones. And then we have those that are purely progestin. And as you say, they work by preventing ovulation, thickening of the cervical mucus, and even making the sperm movement difficult, basically by thickening the cervical mucus. And these hormonal contraceptives, they can come packaged as oral pills. We have injectables, we have implants, we have hormonal intrauterine devices, skin patches, vaginal rings, among many others. But today we're going to focus on those that are very common in our setting, and I mean Kenya. So we are going to start by looking at oral pills. The oral pill, there's so many brands in Kenya, and maybe we can unmute and say the different brands we've heard about or we've come across to make the session more engaging. You can, yes, Sam?
Postinor too.
Thank you. Postina 2, Peter. Very common and emergency contraceptive. Any other? Yes, Joyce?
We have the microgynon pills.
Yes, we have microgynon pills. You can also type on the chat. We have Lydia pills. Thank you, Jeremiah. I'm seeing Katie saying Femiplan, Postina 2, microgynon. Yes. Among many others. So we know about these pills. They come in a pack either in 21 or 28. Thank you, Susan. I'm seeing Yasmin. Mercy is saying, I hear pills are being used for beauty therapy nowadays. Very interesting. Mercy, you can tell us more about this. And we can also hear the community pharmacists in the group. You can tell us more about this. Do people come to the community pharmacy and ask for pills, essentially to go and use as beauty therapy? And how you go about it? Please feel free to tell us on the chat or unmute and speak. So as I was saying, the pack can come in 21 or 28 pills. So for the 28 pill packets, only the first 21 pills have the active hormone. So for the first 21 days, the woman is supposed to swallow these pills because they contain the active drug. And for the next 7 days, they are either supposed to take the pills that do not have the active drug, or for those packs that have 21 pills. So for those 7 days, they will not be swallowing anything. And this is to essentially allow for the menstrual cycle, for the bleeding period to occur. And for those that have the extra 7 inactive pills, most of the time they contain iron, which helps to boost iron levels in the body. And we normally tell patients to start the pills within the first 5 days of the menstrual cycle, so that it can help as you said, they contain hormones, so it will sync with the body's natural process of hormone production, that is progestin and estrogen. And one of the things that we see most women complain about, or rather say that happens to them when they take these medications, that is the combined oral contraceptives. Most of them complain of bleeding changes, especially in the first months they start taking this. And people can say they have maybe irregular bleeding, or they can complain of the consistency. Maybe it is lighter or it's heavier, but we see for most of them it resolves after a few months. It becomes more regular or it becomes lighter. But it is very important for you to tell a patient, or for you to, when you're talking about this contraceptives, maybe in your respective social media platforms, to tell them that these things are normal, but in case they see some of the side effects that are alarming, of which I'll mention them, then they need to seek medical help, go to the nearest pharmacy, go to the nearest clinic. And we normally call these danger signs, and this can include abdominal pain, chest pains, eye problems, and severe calf muscle pain. So in case this is something they experience, it is important they seek medical help in their respective places I've said. So as I said, we have two types. We have combined oral pills and we have progestin only. So for the combined oral pills, we usually see that they're 99.7% effective when used correctly. And what I mean by when used correctly, here we don't have any missed doses. The woman tries to take them at the same time every day. If you take them in the morning at 8 a.m., try to maintain in what's in the body. Another thing we can see is, in case you miss a pill today, do you stop taking it? And this depends. If, for example, I realize that I have forgotten to swallow my pill and it's now, I usually take it, let's say, at 8 a.m. and now it's something like 1 p.m. or it's something like 12 a.m. Sorry, 12 p.m. I should be able to take that pill. But if it's past 10 hours or 12 hours, now maybe I can take the pill the next day, but at the usual time I take it. I should not now stop taking the pills because I missed that day or I'm late to taking it. Continue so that you can maintain the same, so that you can maintain the levels in the body. And for combined oral contraceptives, one of the things that we usually see that is a side effect is that it increases the risk of cardiac and blood clotting side effects because of the estrogen in it. So it's very important that when a patient comes to your community pharmacy, or for women who are from giving birth and mostly through cesarean C-section, who are very susceptible to developing cardiac issues or blood clots, they don't take combined oral contraceptives. You can encourage them to go on progestin-only pills. And another reason this is important is because the estrogen in COCs has been seen to reduce milk production in breastfeeding women. Again, they are not the best candidates for this. Tell them to go on POPs. As you've seen, on the other side, I've said POPs are 99.5% effective if used correctly. Again, the timing of taking these drugs is very important, avoiding missing these drugs as much as possible. But the most important thing there is looking at who is the best candidate for what and initiating them at what time, and advising the patient to be as compliant as possible for this to work well. So we're going to look at the advantages and limitations of oral contraceptives generally now, not POPs or COCs. So, and we are comparing this with the other methods, like injectables, implants, you name it. So one of the advantages, it's easy to use. You just need to swallow, yeah? And at the right time, obviously. And then in case of any undesired effects, it's very easy to reverse this because you just stop promptly. And then maybe after a few days, within the month, those undesired effects should be able to reverse. Another thing, they are available in most areas in our setting. You can go to any outlet in a community pharmacy and you'll be able to access this. Another bit is affordability. Yeah, so Another thing about oral contraceptives, as I've said, is the affordability bit and accessibility. So compared to the other methods, these are easily found in our setting. But one of the things we see that is a limiting factor for this, they will prevent pregnancy well, but if used correctly, but they are not able to offer protection against STIs. Things like gonorrhea, syphilis will not be protected against that, but as well as HIV and hepatitis B. So you have to use a backup method, maybe like condoms to prevent this. And then another thing we did, for it to work effectively, you need to take it every single day, at least at the same time. Yeah. And then another thing we usually see, effectiveness may be affected if a patient is on other drugs, such as anti-TBs, antiretrovirals. And this is something the healthcare provider, if you're dealing with a medical doctor or a pharmacist, they should be able to advise the patient well on this. Maybe look at the dosage or look at other methods that they can use on these drugs. So that is the bit on oral contraceptives. And then now we're going to look at injectable contraceptives, still under hormonal contraceptives. So I've shared an illustration there. We'll talk more about it. So to get into injectable contraceptives, again, we have two types. We have combined injectable contraceptives and we have progestin-only injectable contraceptives. So the concept in terms of mechanism of action is the same with the oral contraceptives. So these ones will be delaying, preventing ovulation. But now if you have progestin-only injectables, just like progestin-only orals, they are better used by breastfeeding women or people who are susceptible to develop cardiac issues or blood clotting issues. This is the best for them. And then it is the most found in our setting compared to combined injectables. And in our setting, we have brands like, we have injectables like DMPA-IM, which in full is depomedroxyprogesterone acetate intramuscular. And then we have the same injection, but now given subcutaneously. And then we also have norethistron internet, which is given intramuscularly as well. And I'll talk about the DMPA-IM and DMPA-SC. Most of us know IM, and most of us maybe we refer to it as depo. And that is the most common term. Maybe you can hear the mwananchi say depo, amedunga depo, or kitu kama hiyo. That is the most common name, or the injection. You will never hear someone say the full name, depomedroxyprogesterone acetate. And then for progesterone only injectables, they are 99% effective if used correctly and consistently. And for injection, the effectiveness depends really on are we giving them on time, and is the patient coming to the hospital or at the pharmacy after every 3 months, for example, for the DMPA-IM or DMPA-SC, because it works, the interval is 3 months, after every 3 months. So before I go into the advantages and disadvantages, I want to talk about DMPA-SC and DMPA-IM. So as I've said, they contain the same drug. The only difference is the mode of administration. SC is injected subcutaneously. And for those of us maybe who are not in the healthcare space, what this means is the way we inject them at a 45-degree angle, and we target the subcutaneous fatty tissue. While for the DMPA-IM, we inject it intramuscularly, meaning we target the muscular tissue in the skin, and this is given at 90 degrees angle. So basically what this means, for the SC, someone can self-administer. And maybe for the common SC injections we know outside contraception, I can say things, for example, people who self-inject insulin, they do it subcutaneously. And most of the time for DMPSC, we target the fatty tissues, maybe on the belly, on the thighs, the anterior part of the thigh, where you have fatty tissue, or even the outer parts, on the upper arm, the outer parts. So for the IM, someone cannot be able to self-inject because you need a healthcare professional to do this. Number one, there's a technique involved in doing this. For instance, if you inject on the buttocks, you need to avoid pricking the nerve that is there, and it will take an expert to know where to inject, because if you prick a nerve, we have some of the issues that can come up. You can lead to immobilization of the person. So such things are taken into consideration. And then when you talk about SC, as I've said, it is self-administered subcutaneously. So when we compare the two modes of administration, many users report SC to be less painful, and it is because of the way it is injected, the angle and the tissue that is targeted. But both of them are able to offer protection against pregnancy for a 3-month interval. So that is on our comparison between the SC and the IM. When we look at injectable contraceptive, and specifically the progestin only, there are some of the advantages and limitations following use of this. For the advantages, we see that progestin-only injectables are highly effective and safe. We say they have 99% effectiveness as long as someone goes to get the injection within the specified time frame. They are convenient compared to oral pills because you don't need to take them daily. You don't need to be injected daily. Another thing, they're discreet because some users are usually very ish about privacy, people knowing they're taking this. They want that privacy. So this is a method that offers that. It's also suitable for breastfeeding women, again, because it doesn't contain estrogen. And compared to other methods, as we'll see, IUD, the pelvic exam is not required for this. There's no risk for cardiac and blood clotting side effects, again, because it does not have estrogen. Some of the limitations following this, again, it does not offer protection against STIs, HIV, hepatitis B, so that's a downside for using this. And then after discontinuation, return to fertility can be delayed for 4 months or longer. So users need to take this into consideration in case they want to conceive. This is something that can be a downside. And then for something like DMP, you have to visit a healthcare center, or that could be a clinic or a pharmacy for it to be administered. But then again, we have DMPSC that can be self-administered as long as the user is well taught by the provider. They can do this at home. So that is for injectables. And in case you have any questions, please, you can write on the chat and I'll be able to answer after the session. So swiftly we move to implants, which are still part of hormonal contraceptive methods. So implants contain progesterone, and they're in form of a capsule or a rod, and it's usually inserted under the skin of the upper arm, and particularly in women. So they release the hormone, and in this case, it's progesterone, slowly over a period of time. And we see that implants can last for 3 to 5 years, depending on the type of implant. and they are 99.9% effective against pregnancy. And we usually see that implants can offer protection against pregnancy even up to 24 hours post-insertion. So that's a very good thing. And in Kenya, the most common types of implants, we know we have Jadel, we have Implanon, Levoplant, and if you know any other type that you've interacted with, you can type on the chat or you can just unmute and share with us. But these are the most common. So there's a very nice illustration here showing where the implant is inserted. Hope you can be able to see. So normally this is inserted in hospitals rather than in pharmacies. So for this one, like a patient has to go to a clinic or a hospital setting because the way it is inserted is through a small surgical procedure and it is input there. And as you said, slowly over time, it produces it releases the progesterone. So, and as you've said, progesterone, just like in progestin-only injectables and oral pills, it works by preventing delaying ovulation. So some of the common side effects following use of implants include, we have, and this is the most common for most women, they complain about the bleeding changes. Some of them experience amenorrhea. Amenorrhea means loss of bleeding. And then we have spotting, we have intermenstrual or prolonged bleeding. Some other side effects, we have headache, dizziness, breast tenderness, mood changes, weight changes, and mild abdominal pain. So what are some of the advantages of contraceptive implants? They are highly effective and offer long-term protection. We've said they can be used for up to 3 to 5 years, depending on the type of implant that is input. We've seen they can start being effective as soon as 24 hours after insertion. And for people who use implants, they usually say there's no interference with the act of sexual intercourse. And I'm talking about both women and men. And there are no frequent clinic visits if you compare with, let's say, injectables like DNPIM, where you have to go after every 3 months. So this is quite convenient for most people, but some of the limitations following use of implants during insertion, removal, and you have to go to hospital for this, and it has to be done by an expert, a trained healthcare professional. Again, it does not offer protection against STIs, HIV, or hepatitis B. So a backup method has to be used to give protection against this. And then another thing, we see that return to fertility may be delayed. This can go even up to 1 year. So this is a very big downside of using contraceptive implants for people who want to conceive immediately after they've discontinued the use of a contraception. So that's it for contraceptive implants. Again, for contraceptive patches, which is part of hormonal contraceptive methods, this is also one of the things that is common in for contraceptive patches, we'll see it is a small, thin, square, flexible plastic worn on the body that continuously releases progestin and estrogen through the skin into the bloodstream. So a new patch is worn every week for 3 continuous weeks. So this is for 21 days, you wear a patch, and then after the 21 days, you remove the patch to allow the monthly menstrual bleeding. And then after the bleeding, you'll put another patch. So where is this patch normally worn? It's worn on the upper outer arm. You can also wear it on the back, the stomach, abdomen, or the buttocks, but never on the breast. And when you put it, you should put in on the area that is clean and dry. And another thing that we, as we've said, put it on Sunday, try and put it on Sunday again on week 2, on week 3 on Sunday. This again is just like the oral pills. You try to take them on the same time every day to increase effectiveness. And when you put it after every week, if let's say you're putting it on the upper outer arm, you don't need it to put on the same to put it, that is on the same spot. You can try and rotate the places to avoid irritation so that. So effectiveness of contraceptive patches depends on the user, and the pregnancy risk is very great when a woman is late to change the patch. As you've seen, I've shown there an illustration of where you can put it. Let's say if you're putting it on the upper outer arm, that is where to put it. But the most important thing is to change it after every week and to make sure like you rotate the areas that you're putting it to avoid irritation. So some of the side effects following use of patches, we have skin irritation at the application site, but this can be easily mitigated by changing the spots of putting it. And then we have flu symptoms, we have vaginitis. This is inflammation and irritation of the vagina. Changes in bleeding patterns because it is a hormonal method. We have abdominal pain, breast tenderness, and some patients complain of nausea and vomiting. Some of the advantages of the patches include ability to self-administer, and it is non-invasive, so you can do it at the comfort of your home. Another great advantage is return to fertility is almost immediately after you discontinue use. Unlike we've said the contraceptive implants can take up to 1 year, the injectables can take up to 4 months. For this one, most users report return to fertility being almost immediately. The weekly dosing is very convenient compared to daily dosing of pills. Some of the limitations of these patches is they're costly. If you compare to other methods like orals, injectables, and for some of the pharmacists who are here, you can tell us maybe like how much do this go for? Yeah. Again, another limitation is the irritation that comes to the, the application sites. And then for some of the patients, it does not offer the discretion that they might want. So, putting it on the upper outer arm, someone can see this, and some people are not very comfortable with this. Again, it does not offer protection against STIs and, and hepatitis B. Effectiveness is based on the user. So this can be very, very tricky because if you don't use it well, you risk getting pregnant. So before I go to vaginal rings, maybe we can look at a few questions, or if anyone has something to add on the things we've said, please feel free. Do we have questions on the chat box? Yes, Zedaida?
Yes, I have a question about the patches. Now, since you're putting it weekly and you're not changing it every day, what happens when now it comes in contact with water because it's in your body and you're breathing every day, I assume? So yes, I want to know how that works.
I'm sorry, Jadeda, can you come up again? I was not able to clearly hear you.
Okay, maybe. Oh, okay. Maybe it's the echo from the unmuted mics, probably. Can you hear me now?
Yes.
Okay. So my question is, for the patches, because they're in contact with your body and you're bathing, are they like water resistant, or like do they peel off after you bathe or something? Like how do I prevent that from happening? Because now, I'm going to bathe and stuff. Yes.
Yeah, thank you for that. So most of the time, if you see these contraceptive patches, the adhesion that is put there is able to stick at least for a week. And if you put it well, it will not be able to peel. But then again, after some time, because of the contact with water, it can start peeling off. But you see, you're using it for a week and changing it. So you can try to place it in a way or in a position that is not as easily or as much in contact with water. But for sure, water is something that can affect it. Yes.
And maybe to add to that, one of the reasons as to why the different position that is recommended, one, there's minimal irritation compared to there's a question that I saw in the chat. Somebody was asking why not on the breast. By default, most ladies will wear bras, and with the bras that you're wearing, it's actually closer contact and more risk of irritation when you're moving and all that, and therefore then you have a risk of actually removing it at that point. That's number one. Two, the breast tissue is softer, but also with a different, I would say the tissue is different from what tissues are available in the other patches that we're talking about. You'll find when you're told the next on your arm, you have a relatively higher blood circulation in your arm than in the breast. So the amount that will be absorbed will be higher. Normally, the standard of what is expected is on your arm and the different parts, except for when you're in your breast, because there's limited blood circulation to the breast unless you're aroused. So that is a different ballgame. So how do we guarantee that there are sufficient concentration will get into your body? So the irritation aspect is a risk, absorption level is a risk, and then the contact level. So then your chances are you will remove it before the 1 week elapses. And they're relatively expensive, as already been indicated, over 2,000 shillings or thereabout for a pack of 3. That's all I wanted to add. Thank you.
Thank you, David.
I think I have another concern now on that. We all have different kinds of bodies. There are people who are more oily than others. There are people who sweat more than others. And you cannot, sometimes if you have an oily body, you might place it when your body is dry, yeah? But over time, you'll still produce the oil. So does that affect how it sticks? And now it means that some people can have it for a maximum of 3 days and others longer. Like, yeah.
So by default, yes, people will have different bodies and the different oily bodies, but the difference actually, and what is one of the magics of what God's creation is, normally the secretion of sweat and actually even the oil secretion from the sebum and all that is mostly on exposed tissue. The same way when you have a cut and you apply elastoplast, normally you'll never sweat on that spot. It will only stay kind of covered and moist because the essence of you is secreting the sebum, which is the oily part of the sweat, and also sweating is because of that exposure to the environment to moisten the space. The patch itself has a moistening effect, so then it reduces the level of oil in that section. Yeah.
Thank you for that, David. Jedida, are you satisfied?
Yes, thank you very much.
Thank you. Sam?
Oh, yes, I have a question. So are these contraceptive patches the same ones that are being used within the LGBT community, especially among trans men? And if so, what are the advices that you would give to someone before giving them?
Thank you for that, Sam. Very interesting question, because from my understanding, most trans men, when they're using this hormonal supplementation, which can involve using things like contraceptive patches, they are usually targeting the estrogen and progesterone. So I'd say if that's their aim, to get this progesterone and estrogen, this can work. And I think I don't have maybe any specific advice given to them other than maybe how to use it and some of the limitations they might get from it as well. So one of the things we saw, if you're using something that has both estrogen and progesterone, the estrogen in that can increase your risk of developing things like blood clots, and this can bring about cardiac issues. So this is a very important thing to point out to them, that they're at risk of this as well. I don't know. This can also be a discussion from the rest of us. What do you think about using contraceptive patches for transgender men? Yes, Joan?
Yeah, my question is on DMPAIM, and especially on the site of injection. My clarification is on whether it's a myth or is actually true that when you do the injectable, the DMPAIM on the gluteal muscle, especially on a fat client, especially a fat lady, that it can cause some crystallization on the site of action, and therefore interfere with the absorption of the drug. Is this correct, or it's a myth?
Thank you for that, John. And before I answer this, I asked if there's anyone who has a contribution on what I'm asked in regards to use of contraceptive patches in transgender men.
Okay. Thank you, Wendy. Maybe I would want to contribute a bit. Not as well informed as much, but normally when we look at it in terms of use of the contraceptive patches, for the patches, mostly they're estrogen specifically only. So the question is, when you're talking about transgender men, we're looking at women who are under women who transition to being men, or men transitioning to being women. That is the question that I would want to clarify. On one end, if it is women who transition to be men, they are on testosterone as well. So definitely not recommended to use these patches. And the essence of it is estrogen counteracts the testosterone effect, which is the masculinizing hormone. So if you are masculinizing and then demasculinizing at the same time, there's a negative effect, I would say neutralizing effect at that particular moment. For men who are converting to women, there's a tendency, and actually it is not indicated for use. Let me make that clear. It is not indicated for use for feminization and actually having more feminine features, but it has been used by people in different cases. Safety, efficacy profile, and all that is not as clear, and therefore then I'm not able to stick to it as it is, but it's something that people have used mostly to kind of help feminize the men who are transitioning to be women. Yeah. And
Thank you,
probably I would
David.
answer the question from John as well, just in passing. Yes, it is an assumption for sure, and the assumption is normally that fat people have fat in their gluteal muscles. Unfortunately, based on our understanding of anatomy, however much you might have big hips and everything, fat tissues do not accumulate in your gluteal muscles. It is mostly muscles, and therefore the injection is to muscles, and muscles have improved blood circulation. The myth that people normally have is that because you're fat, you have more fatty tissues in your gluteal muscles, and therefore then chances of blood circulation taking the injected IM into circulation will be reduced. That is a myth.
Thank you, David. I think that is well answered. And again, on that question John asked, it's all about the technique and administration of that injection. As we've said, we are targeting the muscle, and it's the deep deltoid muscle, or in case of the bang, we are targeting the deep glute muscle. So in no way, if the healthcare provider is doing it well, should it cause crystallization? And we usually advise before someone is, before you do injection, you need to shake the vial to make sure that all the tiny drug particles suspended in the liquid, they mix well, and then now you can inject the patient. If there's no other question, you can move on swiftly. I believe I've answered all the questions. Do you have anything on the chat?
John's hand is still up.
Yes, John?
No, I don't have any other question. I'm satisfied with the answer. Thank you.
Okay, thank you.
Oh, thank you for that.
Maybe Wendy, before you
Okay.
continue, can come in here. I'm just getting to clarify for all of us who are here. This session is more of health communication masterclass series, and it is mostly to help us get more information around these contraceptive methods and family planning options that are available to inform one, our own knowledge at individual level. That's number one. Number two, our communication, because we're engaging and sharing healthcare information in different spaces. And specifically in this context, we're looking at it from family planning options. And I would want to just bring up a couple of items that I know has already been discussed. And this is what I would maybe put it as a guide for the subsequent sections when you're thinking about it. When you're communicating health information, and this medical scientific information and the content that is already shared that is available in the slides, the question is, whoever is listening to you, what do they need to make them make an informed decision on which service to use and which one not to use? So that one, you look at the science. How effective is this method that we are talking about? Already, some of it has already been mentioned by Wendy, and she'll be covering the other parts as well. The effectiveness. Is it safe for me? And after I've used it, if I want to get pregnant again, how long does it take? Or is it going to be a sterilization method? Because yes, we don't want to get pregnant at a particular moment, but sometimes we want to after a period of time. So the question is, will I be able to conceive to have my baby? And how do you communicate that? That communication, if you say, probably you tell somebody, oh, by the way, it might not come back. Somebody will not use the contraceptive. You are exposing them to the risk of having more babies than they wanted to have just by default, by the virtue that you did not communicate accordingly. So that is important, and I'm encouraging all of us to look at it and look at it from that level. So that is important. Then another key thing that comes in, the convenience. When you're dealing with anybody around using contraceptives, and I know even at a personal level, you were in this conversation, you're asking yourself, will I be going to the pharmacy every other time to get a pill? Or will I have to take a pill every morning? What if I forget? Or what if I'm in an environment, probably I visited a friend, and I don't want to take my pill at that morning because they'll see that I'm taking a pill, and I want to be discreet about it. So those are the convenience factors. How do you communicate those convenience factors when advising somebody on which method to go for and which method not to go for? And I'm hoping that kind of information will guide us as we go through the other parts, because there's more information coming in, just giving context so that if you're going to communicate, how do you communicate it to help the person make an informed decision, but an informed decision from a point of understanding, because you know what you're telling them and you understand why it happens the way it's happening. So that would be a good part of it. So yes, I will stop at that and hand it over back to you, Wendy. Thank you.
And thank you, David, for that. So moving on swiftly, the next hormonal method we'll be talking about is vaginal rings. So these are not very common in our setting, but they're still there. So how it works, number one, it's placed high in the vagina, and it continuously releases the contraceptive hormones in the vagina, and they're able to be absorbed locally from there into the bloodstream. And again, it's just like injectables. We have combined vaginal rings and progestin vaginal rings. So for the combined, they have estrogen and progestin. The mechanism of action is the same as combined injectables. So I'm not going to get into that as much. And effectiveness depends on the user. So how you place it, and after how long do you take it out, and after how long do you place it again? This will affect the effectiveness rather. So one thing we'll see about vaginal rings, for instance, for the combined, the ring is placed high in the vagina and left for 3 weeks, and you remove it on the 4th week to allow the normal menstrual bleeding. Again, because it's a combined hormonal method, it is not suitable for breastfeeding women and for those people who are susceptible to getting blood clots. They'd rather use progestin vaginal rings. So for the progestin vaginal ring, we will see the difference it has with the combined vaginal ring, aside from it having only progestin, is that it is placed in the vagina for 90 days. This is 3 months. And then after that, it is removed and replaced with a new one. Therefore, because it has only progestin, it is suitable for breastfeeding women. And then we see that it prolongs lactational amenorrhea. Let me explain what this means for those of us who do not know this. So for women who are breastfeeding, and again, some people usually say this is a myth, but it has a scientific backing. Sometimes we see that naturally they are less prone to become pregnant during that breastfeeding period. However, this only is true for those women who exclusively breastfeed and up to 4 times a day. This is because we usually see that the levels of progestin produced normally in the body are very high. So in a way, this becomes like a method of contraception, because high progestin levels are able to prevent or rather delay the ovulation, because you will hear some of these women say they are not experiencing periods for that amount of time that they are breastfeeding, up to a year for some of them. Therefore, they're not able to get pregnant. Some of the advantages of vaginal rings, as we've seen, is the convenience. For combined, you only have you put it and it stays in place for 3 weeks. And then for the progestin only, we see it's in place for 90 days. So it improves adherence compared to maybe oral pills that you have to take every day. Maybe you have to set a reminder, or you have to just remember yourself that you have to take this pill. So that can lead to you missing the doses and therefore reducing effectiveness. Another thing, you only have to, you self-insert, so you don't have to go to the hospital or to the pharmacy, except maybe to buy them. But if you buy them and you stay with them at home, you reduce your visits to the healthcare center. Return to fertility is almost immediate, again, like contraceptive patches. If you discontinue it, you can get pregnant as you've planned. Some of the limitations, again, as I've said, it is user controlled. So again, this can be a limitation, because if you don't remember to put it in time, effectiveness again will go down. There's risk of pregnancy. It is unsuitable for women with hypersensitivity to silicone rubber. So really, these are not the target. If you're hypersensitive to this, please don't use this. Or again, this is something we can tell our audience when we're communicating to them on the different platforms. This is something that is not suitable if they are allergic to silicone. It does not offer protection against STIs. It's not suitable in case of UTIs, endometritis, and people who have a history of PID. And this is because, as you've said, the administration is through putting it high into the vagina. Number one, there's risk of infection if you do not wash your hands well, if you don't, the way you put it. But then again, when something goes into the vagina, for methods that involve you using this, they increase your susceptibility to these conditions. And then for progestin vaginal rings, for them to work effectively, we need active and exclusive breastfeeding. That is when the efficacy is at the highest level. So that is it for hormonal methods. Now we can look at intrauterine contraceptive devices. So for intrauterine contraceptive devices, we have 2 types. We have the copper IUD, and the hormonal releasing devices. So what is an IUD? It is a flexible T-shaped plastic device that can either contain a hormone, or it can now be the one having the copper wire intertwined on it. And it is put on the uterine cavity. And as you've said, we have the copper-based devices, and these ones have the effectiveness and they can be used for up to 10 or 12 years, while the hormonal releasing devices are active for up to 5 years. So how do they exact their mode of action? For the copper IUDs, they release the copper ions in the uterine, and these are very toxic to the sperm. So they will inhibit movement of the sperm. They'll slow them down. That is one way. Another way, because they take up space within the uterine cavity, they prevent fertilization, they prevent implantation of a fertilized egg. That is another way. And then we have both of them now, the hormonal and copper IUDs, preventing fertilization by interfering with sperm mobility. I've talked about that one. And for the ones that contain hormones, and in this case, they usually have progesterone. They don't have estrogen. They thicken the cervical mucus. So again, they slow the movement of sperms, they suppress ovulation and thin the endometrial lining in such a way that it cannot allow implantation of a fertilized egg because it's very thin. IUDs have been known to be 99% effective if placed and used correctly and consistently. So when we compare copper-based and hormone-releasing IUDs, what are some of the differences? What are some of the aspects we see? For example, for copper-based, we've said it can be effective for up to 10 years, so it offers long-term protection against pregnancy. It can also be used as an emergency protection or contraceptive method if it is inserted within 5 days of unprotected sex. But it has to be within that time frame for it to work, because as you've said, it is able to prevent implantation of that fertilized egg. It can be used immediately after delivery, especially for the hormone releasing, because you've said it is a progestin only containing method, so it is very effective after delivery. One of the things we see with the copper-based IUDs, for most women, they complain of bleeding changes, especially within the first year or the first 6 months. And then after that, it resolves. If they were experiencing heavy bleeding, it can become lighter. If they were experiencing like increased number of days, maybe it has gone to 7 days, it has gone to 2 weeks, it should go back to the normal number of days they were experiencing the bleeding. And then for the hormone releasing, as we've said, it is suitable for breastfeeding women. It is also suitable for women who experience heavy bleeding, as it minimizes bleeding and cramping. It provides benefits in reduction of endometriosis symptoms, and some of these symptoms are like heavy bleeding, as you've seen, and very painful cramping. So this can be a benefit for women who experience endometriosis. So what are some of the advantages of IUDs? As you've seen, it is 99% effective and safe. It provides immediate protection after insertion, just like the implant after 24 hours, protection against pregnancy takes effect. Efficacy is not dependent on the user because, again, it is inserted by a healthcare professional. And this one has to be done in a hospital or a clinic where we have the appropriate prevention practices against infection. But nonetheless, if efficacy does not depend on the user. No further cost following insertion. Again, maybe for the first year or the first 2 years, you can be told to go back to the hospital and see if it was, it's still in the right place. after insertion, but you don't have to go and get it every other time. So that is what I mean by the cost is reduced. And then immediate return to fertility following removal. Some of the limitation, again, does not offer protection against STIs and HIV. Backup method should be used. It requires a trained healthcare professional to insert and remove. Again, we have to take into consideration if the area in which or the room that we are placing our patient in is appropriate, like it is a sterile place to prevent infections. It may be expelled or translocated if it's not properly placed. A very rare occurrence can happen where some patients can experience uterus perforation, and this is an emergency. A patient should go to the hospital, but this is a very rare case and can only happen most of the time if it is not well placed by the healthcare provider. But if those things are taken into consideration and it's placed well, this should not happen. So that is it for intrauterine devices. We'll go to barrier methods, and here we had mentioned examples such as condoms. We have the diaphragm, cervical caps. These are some of the examples of barrier contraceptive methods, and the most common in Kenya is condoms. And condoms, we have male and female condoms. And as we've seen so far, there's no method that offers protection against STIs, HIV, and hepatitis B. But when we look at condoms, they do offer this. They offer protection against, number one, pregnancy, and number two, they offer protection against STIs, making it superior in that sense compared to the other methods we've talked about. So, male condoms and female condoms. What is the difference between these two, apart from the male condoms being used by men and the female by women? We usually see that male condoms have a higher effective rate compared to the female condoms. They offer between 87 to 98% effectiveness if used perfectly, compared to the female condoms that offer 79 to 85% use. And when it comes to male condoms, they're easily accessible. You go to any community pharmacy, even other shops, normal shops, you can get this. You go to a government hospital, you can get them, or even universities, they're being offered for free. So they're easily accessible. In terms of usage, most people, if well-trained or if they look at illustrations, they can be able to use this comfortably and easily compared to female condoms. Again, they are affordable in terms of cost compared to female condoms. Another thing about female condoms, they have to be inserted a few hours before the sexual act, unlike male condoms. You just apply it or you use it, you insert it just before the act. So this can sometimes be something that is a downside of female condoms, because you have to remember to use it even as much as 8 hours prior to the act. They're not reusable, and this cuts across for the male and female condoms. Some of the advantages of condoms, the main one, as we've said, is they offer protection against STIs. We have HIV, we have hepatitis B, so they can be used as a standalone or as a backup method with the other methods. They are accessible, affordable, and easy to use. They do not have any hormonal risks associated to them. They provide 80 to 95% protection against HIV transmission specifically. This is very important. They can be regular. They can be a regular, temporary, or a backup method. Limitations: you cannot reuse a condom. You have to use a new condom every time, so this can be quite costly. There's a higher failure rate if used incorrectly. they're not suitable with oil-based lubricants. And then for people who have latex hypersensitivity, again, this can be unsuitable for them. And then we have to think about the environment. If you're not disposing it properly, it can be an environmental hazard. So that is it for condoms, or rather the barrier methods that are accessible in our settings, For fertility awareness-based methods, I don't know how many of us have heard about this, but normally we refer to them as natural family planning methods. And this involve abstaining from intercourse or using a barrier method during the fertile time of a woman's menstrual cycle. So basically it involves being aware of the fertility window, knowing the menstrual cycle, yeah? So women can identify their fertile time using various approaches. So the different methods here, we have calendar-based methods, we have standard day methods, cervical mucus methods, basal body temperature, and this all look into telling us when is the woman most fertile. So for these methods to work, they not only require the woman to be aware of this method, but also their partner should be aware of actually they can be able to tell us the different times in the menstrual cycle. If you are in the ovulation stage, if you are in the menstrual bleeding stage, so someone can be able to track their menstrual cycle. And one of the advantages of the newer approaches is they enhance efficacy of these fertility awareness-based methods and make the method easier for couples to use. For example, for an app, you can share with your partner, they can be able to know your fertility window period, so they can easily cooperate through the abstinence during that period. Advantages of these fertility awareness-based methods: number one, they are less expensive. If it's just you checking out, if it's the cervical mucus method, it's just the woman checking the production of the cervical mucus. If it's the basal body temperature method, it's them measuring or rather tracking the temperature through the days. They do not have side effects or health risks that can come from hormonal methods. Return to fertility is immediately. You choose if you want to get pregnant by next month and you already have the knowledge of your fertility window. When it comes to next month, then you know this is the right time to engage in copulation and conceive. Another good thing about fertility awareness-based methods is that they improve the knowledge of the reproduction system and the menstrual cycle, because for you to know how to use these methods, you have to learn how the menstrual cycle works, you have to learn your body, you have to take keen notice of all the different changes in your body. Again, as I said, for this to work, the partner, the male partner in this case, has to be willing to abstain and has to cooperate. So it is a shared responsibility by the couple. Again, it can be used where other methods are contraindicated. Limitation or downside of fertility awareness methods. It is not easy to use in case of irregular cycles. It can be very tricky for someone to track their fertility window if they are irregular. Another downside, you have to intensively study and understand your body. And for some people, this can be intimidating, and this can lead to risk of getting pregnant if they don't understand their menstrual cycle well. There's a higher failure rate because of this if they're not well trained. It does not offer protection against STIs. Cooperation and commitment is by both partners. If it's only the woman who's willing or it's only the man who's willing to learn this, then this cannot work. So that is it for fertility awareness methods. For voluntary surgical methods, we say these are permanent, and we will talk about the two methods, that is tubal ligation and vasectomy. So for these methods, we are very careful before advising patients to take on these methods because of their permanent nature. So before a client, or rather before you talk to your audience about this, or if someone comes and asks you about this method, as much as you tell them what it entails about, there's a lot of counseling that needs to go into this. Number one, as you've said, this is a permanent method. And most of the time you'll see, like in hospitals, if someone comes for a tubal ligation or a vasectomy, they're given a consent form to sign. So we'll try and understand what tubal ligation is. So tubal ligation is done on females, and it involves cutting and tying the fallopian tubes. It can be done bilaterally, where we tie both tubes, we cut them and we tie them. And this is to avoid fertilization of the ovum, because fertilization takes place on the fallopian tube. So if we cut out this fallopian tube and tie it, we are disrupting the site of fertilization. Therefore, we prevent it from, in case of any, of copulation, we are preventing the sperm from reaching the uterine cavity, from reaching the fallopian tube, fertilizing the egg, and if fertility does not take place, so it will not go to the uterine cavity to be implanted. So basically, that's how it works. For vasectomy, it involves cutting and tying, the vast difference in men. And we know that the vast difference is the passageway for sperm and the seminal fluid. So if we cut this vast difference and we tie it, basically the seminal fluid will be produced, but it will not have any sperm, because the sperm will be produced at the scrotum, but it will not be able to mix with the semen. So for the bilateral tubal ligation, what are some of the advantages? It is 99.9% effective. That's one thing we need to understand. So in case there's some women who undergo this procedure and they fall pregnant, this can be very frustrating, because we assure them of the permanence of the nature, yet there's that 0.1% that they might get pregnant. But nonetheless, most women who undergo this procedure, they get like a permanent solution for pregnancy. And then it has proven to have no effect on women's sexual desire, ability, and performance. It is cost effective long term after the initial surgery, because they don't have to come again and again and again for the procedure to be done. Unlike if you're going for oral pills, you have to buy them. If you're buying patches, contraceptive patches, you have to keep on buying them. There are no significant long-term effects that have been linked to tubal ligation. And then there's this decreased risk for ovarian cancer and PID for women who have undergone tubal ligation. A downside to tubal ligation, it does not offer protection against STIs. And so far we've seen only condoms do offer this. So if a woman undergoes this procedure and to them STIs is something they want to protect themselves against, condoms should be a backup method they consider using. And in case of reversal of this method, like someone has changed their mind and now they want to conceive children, success is not guaranteed. So that is a downside. Again, why we say counseling is very important before someone undertakes this process. This procedure needs specialized facilities. Someone has to go, because there is use of anesthesia, we need it to be done in a room where in case of anything, they can be resuscitated, and it has to be done by a trained healthcare professional. And in most cases, if someone is undergoing tubal ligation, it will be carried out by a gynecologist or a surgeon. Another downside, a patient is subjected to pain and scars. It is a surgery, so someone has to heal after that. They have to be given pain meds if they are undergoing significant pain. And then side effects associated with surgical procedures may be experienced by these patients. For vasectomy, it is 99.8% effective and it is permanent. Again, there is no effect on a man's sexual desire, ability, and performance. And most of the time, there are myths associated with vasectomy, or they affect the man's performance and all that. All this is null and void. They have no effect on that. They are less expensive and easy to perform, and this is in comparison with tubal ligation. There are no significant long-term effects. There are fewer side effects and complications compared to many methods that women use. If you compare it to implants, you compare it to things such as the IUDs that bring like bleeding changes to women, this has less side effects. It's just the pain that the man has to experience during the days after the procedure. Some of the limitations, there is delayed effectiveness after the procedure has been done, and this can be experienced for about 3 months. So it is very important that the patient or the client who has undergone this procedure to be counseled on this and to be advised to use a backup method. No protection is offered against STIs. There is minimal risks and side effects of local anesthesia and surgical procedure following the use of a vasectomy. Actually, that is an advantage, not a limitation. So that is it for the different methods of family planning. Do we have any questions so far? Okay. I can see on the chat a few questions. Again, if you have a question, you can raise your hand or you can type on the chat. Let me start with, we have a question from Jedida. She's asking, what is the allowed age limit for bilateral tubal ligation, and is it done at will? Thank you, Jedida, for that. Number one, I'll start by answering, is it done at will? Yes, every procedure that is done on a patient or any use of family planning method should be at will. As I say, that is why a patient or a client is given a consent form to sign. You should be able to understand what you're getting into, the effectiveness, the side effects, and anything associated with that procedure. And you should be able to give a verbal and a written consent. When it comes to age limits, in Kenya, you will see the Ministry of Health. It gives the healthcare professional guidelines on what age of women can undergo this. It is not like a clear-cut outline that women who, let's say, below 35 should not be given, but they try and tell healthcare providers to look at people who have, do they have any children? Is there willingness for them to conceive in future? All these things should be taken into consideration before the patient is given the consent form to sign. Or is there even any underlying mental health condition that could play a role in them deciding to take this? They should not be told they cannot undergo this procedure, but rather they are told this because to take into consideration, like, this is a life-changing and it's a permanent procedure. So all those things are taken into consideration. And I see you said, I meant, like, can I just walk into a clinic and request it? Yes, you can go into a clinic and get access to a healthcare professional, a doctor or a surgeon. They can tell you all that goes into this procedure, and they can see if you are the right fit for it, and you can be able to get this procedure done. We have another question from Joan. Yes, Joan?
Yeah, my question is on IUD, and in particular the copper IUD. While using it, okay, let's say it has been inserted, can it be on expiry, can it be removed and another one inserted at the same time or at the same day? My second question is, what if it has been inserted and then before the end of its expiry, the string that normally hangs on the vagina comes out? Does that interfere with its effectiveness? And another question connected to that particular question on the string, what happens if say the string removal of when it comes out does not affect the effectiveness? What happens when say on the expiry of the IUD, when now the patient or the client wants it to be removed? Will the health provider be able to remove it without the string, or what is going to be needed for this to happen?
Thank you, John, for that. I was able to catch your two last questions. Kindly repeat for me.
Okay, the first one is
first part of
if say you've inserted, okay, you got the first question. I repeat the first question. Okay, the first question is, can the copper IUD upon expiration be removed and then another one inserted immediately?
As in case the string comes out, how do we get to remove the ID, right? Am I audible?
Yes, Wendy, you are, and that's the question actually.
Thank you for that. So the first thing, if the copper IUD expires, again, I'm trying to understand. So the copper IUD was already inserted. When you say expired, do you mean like after the 10 years, like the time has lapsed, now it can be removed and inserted? That's what you mean by that?
Yes, that is my question.
Yes, this can be done immediately. In fact, the day of the removal, it can be a continuous process. The doctor can remove the IUD and return it immediately if there is no issue with the patient, like there is no condition that they're experiencing, no infection, and they're willing to get it returned immediately. This can be done. Again, it does not affect the effectiveness. As we had seen, after the IUD is inserted, even up to 24 hours after insertion, it can provide protection against pregnancy. And this is also very important because we said the copper IUD specifically can actually be used as a emergency contraceptive device, and it's because of the nature of its mechanism of action. We usually see that it releases those copper ions that are very toxic to the sperm. It affects its mobility, and it can also, like, due to its toxicity, kill them. And then in case of the string being, like, if it's, people usually say string imepotea, haionekani, they can't feel it, or maybe it is not visible. Usually in this case, and this is why people are cancelled or advised in the first year of insertion. The doctor can tell you maybe kuja after 6 months or come back after a year or something like that. And this is for them to check if it is still in the right position. But if the string is not visible, I believe what they usually do is an ultrasound to check if the IUD itself is still in the right position or it has been expelled, because sometimes clients do usually think that the IUD is still there, and in such cases, you might find that it has been expelled from the body. So they'll do an ultrasound to confirm, number one, if it is there, and if it is there, is it in the right position? If it's not in the right position, or if the patient doesn't want it anymore and the string cannot be seen, I believe it has to be surgical. But I'm happy to be guided on this as well by the other professionals or any comments. And you still have a question? I can see your hand up. Okay, thank you for that. Yes, Dawn? I don't think she has a question. So if there are no comments, there are no questions, allow me to share a post survey for us to be able, I'll let my colleague Juliet share from her end. Let me pull down my presentation. Thank you. Thank you so much, Dr. Wendy, for taking us through the session this evening. And I want to believe that we have learned and at least been able to be appraised of the FP machines that are available for us in the market. And even when we are sharing our communication, or you are maybe helping a friend or a sister, a cousin, a family member, whoever that may be, to help them to choose the right family planning method for them. For me, when I was sitting through this particular session, I was just thinking of myself as a young girl in my early 20s, you know. If I'm out there and each and every day I'm taking P2, kila siku nameza P2, the implications that is going to have on my health down the line. And I'm seeing that there are other methods that definitely are able to help me. How then can I be able to get the right information? How then can I be exposed to the right place where I can access this particular methods of products that are quality, safe, and effective? How do I know where I can go to? Is it a hospital? Is it a pharmacy? Is it a clinic? Who am I going to meet there? So for this particular session is to enlighten us that these are the methods that are available.
These are the places where you can go to get these particular methods, whom you can trust to offer these particular methods, and even to understand the side effects that also come with it. If over the period of time that I've been working with APN, I have come to understand that there is no product that is without risk. Therefore, to understand the risks and the benefits of family planning methods as well is very much important. So thank you so much for joining us this evening, and I want to welcome you to join us on this particular survey. This is our post survey, so that we can be able to find out how the learning has been this particular evening. But also I want to confirm that the slides will also be shared with you, so that you can also have some time to go through them. You'll also have them as yours as well. You can use them, create content around them, share information around those particular slides, being that they have been prepared by a professional as well. And with regards to the CPD points, this will definitely be issued. So please go ahead and join me on the survey form. You can scan the QR code on your left, and it will give you access to the form. Right, the link has been posted on the chat. And go ahead and just try and answer these questions. They are easy questions, but still with regards to the topic that we've been covering this evening. All right, your screen is visible. Go ahead and let us know which of the following family planning methods is classified as a barrier method. Okay. I have one response so far. Thank you. I know you're engaging with us on the phone. Keep sharing your responses. These are 10 questions that we are answering. Thank you for your responses. I can see 6 responses already. Keep them coming in. And if you have any questions, or maybe something has come into your mind when we are here on the feedback form or on the survey form, please feel free to share. Dr. Wendy is still on the call with us. Showing 7 responses and counting, and I can see 17 of us are on the call. I'm hoping I can get more responses. Thank you. Thank you for your responses. If you are yet to submit your response, please go ahead and submit. But we'll have Dr. Wendy weigh in and just let us know if we have done well, and then we will call it an evening. The slides will be shared, the recording will be shared, and CPD points for healthcare providers who are on the call will also be awarded to your accounts. These are pharmacists and accountants. You'll definitely be getting your CPD points tomorrow, right? And if there will be any challenges, I'm going to post my contact here so that you can be able to reach me. Thank you. Keep your responses coming in. So far, I have 12 responses that have been submitted. Thank you so much. We appreciate it. So we'll invite Dr. Wendy and Dr. David on the call to weigh in.
Thank you, Juliet. Thank you
just let us know how we did on this question.
On this post survey.
Thank you.
So for the first question, it was asking which family planning method is classified as a barrier method. And 92%, actually 85% of us said the condom, which is correct. So some vehicle caps and the diaphragm. So yes, can go to the next one. Which of these are considered long-acting reversible contraceptives? So we had intrauterine devices, implants, progesterone, injectables, and tubal ligation. So according to the categorization of long according to intrauterine devices, this is because of their long-term nature. We say for the hormonal, they can offer up to 5 years, and for IUDs up to 10 to 12 years, and then they are reversed. If you discontinue the use, pregnancy can, someone can get pregnant. And then for the next question, which group should avoid combined oral or injectable contraceptive? Most of us got it correct, breastfeeding women, and this is because of the effect of estrogen on breast milk production, as well as the increased risk of developing cardiac issues following the blood clots associated with estrogen. What hormones do combined oral contraceptives contain? Yes, progestin and estrogen. That is correct. Again, there was a question asking if injectable contraceptives work by preventing ovulation. I see some of us said it's false, but it is very true because it is a hormonal contraceptive method. And all hormonal contraceptive methods, whether combined or progestin only, work by delaying or preventing ovulation. Hormonal contraceptives cause permanent infertility. Someone said, some of us said true, most of us false, and the correct answer is false. We talked about hormone releasing intrauterine devices being used as emergency contraception as long as they are started within 5 days of unprotected sex. Most of us said it's false. Some of us said it is true. The correct answer is false. The intrauterine devices that offer emergency contraception are the copper releasing intrauterine devices. How long does a single dose of injectable typically prevent pregnancy? We saw it is 3 months. That's the correct answer. Whether it is IM or SC, after every 3 months, you need to get another shot of the injection. What is the signs to watch out for when taking oral contraceptives? Abdominal pain, chest problems. We cannot be able to show the rest. There was weight gain, and I believe there was the calf muscle pain. And the answers are correct for abdominal pain and chest problems because we say there are 4 danger signs. We have abdominal pain, we have chest problems, we have eye problems, and for experiencing the calf muscle pain should be able to seek medical attention immediately. Yes, Chris will share the PDF of the presentation after the class. Which family planning method are you most likely to recommend to a loved one or your audience, and it has minimal or no side effects? We also talked about, someone talked about they will suggest the method that best suits their body and lifestyle. Vasectomy because it has less effect compared to female DMPASC. Condoms cheap and effective against pregnancy and STIs. These are all good answers because for this question there is no wrong answer. Thank you for your participation. In case anyone has something to add on to the conversation, please feel free to do so, and we are going to share the presentation slides on your email immediately after the session. Thank you.
Good, thank you so much. Thank you everyone for your active participation, contribution, and support with this. And definitely, as we already mentioned in the previous engagements, we are hoping that we put to use the conversation, the insights that we're gathering, create content in your space, share it with people, but also let us help drive the engagements. If you've not already engaged with us and our different social media channels, Jipende Jipange, TikTok, whether Instagram and Facebook, please do so and help us redistribute this content. We're creating some, we also will share more with you as we move along the journey. It's a matter of driving the engagement. And actually, Juliet has helped me by sharing the links to the different social media channels. Please reshare. For the pharmacies who are part of the program, we will be visiting some of you from next week, but one. Next week, we are creating the materials. Next week, but one, we will be visiting a couple of you and engaging and seeing where we can support, how we can support, but also giving feedback on some of the discussions we had last week. So let's build the momentum and keep moving forward into the future that we aspire and hope for. With that said, I wish you all a good night and a restful one as we come towards the end of the week. Thank you.